for a long time, and specifically you were talking about heart health.
Sure.
What are the disparities that you see there?
You know, a woman's symptoms of heart disease can be different from a man. You may not have this crushing chest pain, this sweatiness, maybe you collapse or you feel short of breath. It may be much more subtle. You may have jaw pain that actually could send you to the dentist, or nagging back pain, or pain in the right arm instead of the left arm, or you just may be feeling run down or have a cold that you can't shake. And these symptoms are considered atypical symptoms, but that word atypical in itself means a deviation from the norm, as if these set of symptoms are normal, but then we have these atypical symptoms for women, something that is an aberration. When in fact, as Peter has acknowledged, we actually make up 52% of the population, so who's to say that our symptoms aren't actually the normal symptoms? And these are the ones that should really be learned as the mainstream symptoms. And so these, you can see, is part of the lexicon, part of the issues we're having with making certain that we can move women's health forward. Certainly as you move through menopause, a woman's risk of heart disease actually doubles as you go through menopause and begins to equal that of men, and yet we don't have any issues or any specifications addressing what is happening with menopause, specifically with hormone replacement therapy, and we're actually taking another really hard look at that again.
Because it's scary when you think about if someone has that jaw issue and they go to a dentist instead of going to someone like you, what that ultimately
And that's the reason why a woman's first heart attack is more often fatal than a man's first heart attack, because there's such a delay in actually getting medical treatment. And if that isn't enough, once she reaches the medical establishment, she actually might be misdiagnosed there as well. Yeah. And so a woman's heart attack, that first heart attack, is more often fatal. And oftentimes when we see women come in, we can see evidence of a prior heart attack of which they were unaware.
And we're here today talking about this effort by the White House moving forward. Peter, you are a part of WHAM, which is the acronym for the organization Women's Health Access Matters. There's obviously all these questions. There's all this proof that something needs to be done. What can actually be done moving forward when it comes to women and the lack of representation in drug trials?
Well, I think there are a couple of pathways. The first way is for Congress to insist that for diseases that are a general population disease, that the clinical trial should look like the disease state. If in cardiovascular clinical trials, women represent half of the disease population, half of the clinical trial should be women. The FDA is pushing drug companies to do this. It's hard because it requires a new way of recruiting patients. Generally speaking, the traditional way has been to recruit men. That's got to change. It can be legislative, it can be regulatory, or it can be drug companies stepping up to the plate and doing the right thing. I think it's absolutely time for that. And I think that from a recapturing revenue perspective, it's worthwhile. If you can get on your drug label that has been tested in women as well as men, doctors will want to use that drug more because the evidence is there. There's also the relative issue of how physicians prescribe drugs. Physicians have to recognize that they simply can't take data derived from men and expect it to be exactly the same for women. So from a continuing medical education perspective, I think that it's time for doctors to learn how drugs are developed. I mean, you'd think they would know that, but I'm sure, as Jane will tell you, that's not really part or a big, serious part of medical education. So education, legislation, regulation, and a big recognition that we need to do the right thing.
And I know we have just about 30 seconds, Dr. Morgan. I want to touch on, though, often we hear about discrepancies when it comes to representation of people of color in studies, and we talk about the lack of representation of women in these trials as well. How does all of that factor together?
You know, it's incredibly important, and we absolutely are looking at that as well. We want to make certain that all populations are represented. What happens, not only with populations of color, but women as well, is that the data is mostly derived from white men and then extrapolated to all of the rest of us, when in fact whites comprise about 9% of the entire global population. And so we've got to begin to shift that paradigm, not to exclude anyone, but to include everyone, to make certain that drugs that are approved by the FDA are relevant to all populations. And it's not just what is the percentage of this population within the larger population, what is the percentage of that population representing that disease process. Some diseases affect populations greater than others. That's the representation that we need to make certain that drugs are developed that are relevant to those populations that are suffering the most.
Well, thank you both for taking the time to be here today. Dr. Jane Morgan with me in Atlanta,
Yeah.
Peter Pitts, former Associate Commissioner for the FDA.